So thank you for this opportunity to present our work, again, made possible by the SEED grant. Our project was Prehab, development and implementation of a Perioperative Optimization Program for patients undergoing major abdominal operations. And it's something that Brendan and I worked on. So as we know, quality improvement efforts in abdominal surgery have been mainly via ERAS protocols. And these are all interventions that occur in the immediate perioperative period, starting from the day before surgery and continuing until discharge from the hospital. So while ERAS has been successful in decreasing length of stay and also the rates of other complications, our patients still experience significant rates of complications. And we find ourselves often trying to understand why these complications continue to happen. Sometimes we chalk it up to poor patient protoplasm and wonder if it's preventable or not. So that begs the question, can we make protoplasm better? Because if so, some of these complications may actually be preventable. So we often tell our patients, it's a marathon, not a sprint, when we talk about going through a major operation. And none of us would conceive of running a marathon without doing some serious training runs beforehand. And maybe some of us are more serious about training than others. And patients themselves have a natural intuition that they should be preparing for surgery. Often in the clinic before surgery, we're getting questions like, what can I do to get ready for surgery? Should I be on a special diet? Or I'm afraid that my body can't handle surgery. And most of us don't really tell them to do anything specific. At most, we might give them general recommendations like eat healthy or just stay active, which is not terribly helpful. Sometimes we might tell patients to lose weight, but we don't really give them any details on how to do that or any support on how to do that. And maybe we just say, no, just keep doing what you're doing and drink your bowel prep and take your chlorhexidine shower and that's it. So even patients who are really motivated, they may not really know what to do. There's a ton of different exercise programs out there. They just really don't know what they're about to experience, so they don't really know what to do. And it's basically impossible, I think, for anyone to sort out what to eat. There's conflicting nutrition information in the popular media, even in the scientific literature. And so patients often will have their own misconceptions about what constitutes a healthy diet. This is a direct quote from one of our patients. And they're also overwhelmed by their own diagnosis and the prospect of having a major operation. So this really leaves patients kind of at a loss, even if they're really motivated to know what exactly to do before surgery. So here's our typical trajectory of surgical recovery. So we have a stable baseline, a physical function, then a drop due to the insult of surgery, and then a gradual return to baseline, hopefully, or maybe less than baseline, depending on what happens. If we add ERAS, we think that this will sort of attenuate this drop a little bit and maybe speed the time to recovery. But again, ERAS really only happens in the immediate perioperative period. So if we add Prehab, then the idea is that we would increase their physical function before surgery. They experience that drop still, but then they're able to get back to the baseline a little bit faster than the typical trajectory. And then if we add a structured rehab program, then we could potentially shorten that post-op recovery even more. So what is Prehab? Well, it varies from center to center, trial to trial, but generally it's a pre-op program with the aim of improving physical function, usually with multiple components, including some level of exercise, some nutrition, and maybe some others like stress reduction or smoking cessation. Some centers will have patients come in for supervised workouts where they come on the treadmill, they go to the gym, and they have someone watching them. But a lot of them are also home-based. The ACS Strong for Surgery program has added Prehab to their list of things to do before surgery or to consider. And there is like a sort of screening form, but there's no specific Prehab guidelines or programs within Strong for Surgery. So some centers have started doing Prehab. A lot of the data comes out of McGill. But what they found is that Prehab improves functional capacity before surgery and offers a faster return to baseline after surgery. It's most beneficial for patients who have a lower baseline fitness. They need something to improve on. And it attenuates post-surgical losses in lean body mass, and most recently found to improve 5-year disease-free survival in colorectal cancer. So why isn't everyone doing it? Well, first, one size does not fit all. The easiest thing to do from a logistics standpoint is just to make a general program for everyone. But if a program isn't personalized, then it won't be that effective or attractive to a significant portion of patients. So adherence may be poor because of that, and often patients need a lot of coaching because they're feeling overwhelmed, and they actually need the specific barriers that they have in their own lives to changing some health habits like eating healthy or exercising. And if they don't address those, then it's very hard to just take on a one-size-fits-all program. And personalizing a diet and exercise program for each patient, following up and coaching is really just not feasible for busy surgeons in a busy surgical clinic, even if it does seem like a great idea. So with all of these, all of this background in mind, we have our overall objective, which was to develop, implement, and test a multimodal prehab and rehab program for patients undergoing major abdominal surgery. Our specific aims were first to identify patient preferences for a perioperative program. Number two was to build a prehab and rehab program for patients undergoing major abdominal surgery. The third was to pilot and operationalize the program. And the fourth was to determine its effect on outcomes. Our hypothesis was that a personalized intervention with intensive monitoring and coaching would improve adherence outcomes. We also felt that modern technology can be leveraged to improve patient engagement, collect adherence data, and then provide coaching based on that adherence data. So our first aim was a qualitative study to identify patient preferences for such a program. We conducted 44 semi-structured interviews with perioperative patients. Some were post and some were pre. We focused on their experiences that they had around the time of surgery and what their preferences would be for a program if we had one. We coded the transcripts, and then we used thematic analysis to identify a conceptual model. So a couple of major themes emerged. The first one is that patients are extremely overwhelmed. So they have a lot of uncertainty and fear about what might happen. Many talked about feeling like they were totally out of control and very vulnerable. Another major theme that emerged was that patients trust their surgeons a lot, and really were committed to doing pretty much anything their surgeons told them to do. So these are our two major pillars of our model: fear and trust. Like, this is what our patients are experiencing before surgery. And then one more theme emerged, and that was that they're very highly motivated. So it's kind of related to their overwhelming fear of complications, but they were very motivated to do anything it would take to improve their outcomes. So we see that patients are experiencing this very scary pre-op period that also happens to be very motivating because they want to take back some control over their lives that they feel like they have lost. And then there's this intense relationship that they've formed with their surgeons where they literally will do anything we tell them to do, like give up the fast food, start working out, drink 4 liters of Go Lightly, and let a stranger cut you open. And these forces sort of come together and create this opportunity where we as surgeons can induce an actual behavior change in patients in ways that they would otherwise not consider. You know, it's probably things that their PCP has been telling them every single year in their annual checkup for decades, like lose some weight, you know, start exercising, stop eating sugar, you know, cut back on the drinking. But in this situation with surgery looming, this might be the perfect opportunity to make that happen. We also ask patients about their preferences on how a program should be administered and what kind of content they want. So there was a range of opinions on high tech versus low tech, but most patients actually wanted a more high tech program, like a mobile app or activity trackers. All of these patients were totally fine with sharing their data with their doctors. In fact, they said, I'm dying to share my data with my doctor because I don't know what to do with this heart rate information and I want some coaching. And some patients wanted less coaching, some patients wanted more, but all of them felt like it would be important to have some level of accountability for them to stick with the program. Everyone wanted the coaching to be remote. No one wanted to come in for that. Everyone wanted a personalized program that was geared towards their specific needs, their specific personal fitness, their disease, and the type of surgery they're going to have. But they also wanted some flexibility. They wanted to sort of have a menu that they could choose off of depending on their preferences. So we completed this aim. It basically set the tone and the foundation for every other part of this project, which was to build a prehab and rehab program for patients undergoing major abdominal surgery. So I'll turn this over to Brendan now.
So good morning. We built a mobile app that was going to be synced with an activity tracker, and that activity tracker could be an Apple Watch, or we also use a Garmin exercise band, so that way the app is available on both platforms. The app makes sense because it gives the ability for some accountability and coaching and personalization. As Cindy mentioned, it does have the downside of being a little high tech, but what we work towards is getting some of the enlisting help from the caregivers for those that feel less capable of doing that, and have the participant wear the tracker, and we've had families engage in that way. And this, of course, has the three components that are going to be essential, which is exercise and nutrition, and then working on specifically unhealthy habits, smoking and alcohol use, which is a pretty significant element for some of our patients as well. And so you guys saw thus the trajectory that we believe, or we are hoping we can change for these patients in terms of the recovery. That's our hypothesis. So if we change that trajectory, we came up with this little logo, which I think you guys will soon be getting on bumper stickers and all kinds of swag. We spent about half of the year working on this. We were working on the word zenith for a long time instead. It turns out Z is a really hard word, but this power logo we expect to see broadly soon. So for the app, we ultimately partnered with a startup called Pattern Health. We looked into lots of different options, including in-house development. And we felt that ultimately working with somebody who already had some expertise in the backbone of this made sense. Pattern had worked with the cardiac transplant program on a rehabilitation program, so they'd also gotten inside of the Stanford IT security world, and that jumped us forward. So this is some examples of what the patient sees. They get a few tasks to do each day: surveys, exercise, some videos to watch. The app pulls in activity from their Garmin or their Apple Watch, and it will log workouts for them. It also allows them to log their own workouts if the activity tracker isn't actually picking up the workouts automatically, and gives them some surveys to measure quality of life. They also get to see their progress each day to help them with motivation to continue to push forward with their prehabilitation. Then specifically, the exercise component has three components, which is the strength and cardio and also stretching. And for each of these components, there's 4 levels of difficulty for each exercise, so that it can be personalized for the patients. The patients get reminders to do their exercises on an ongoing basis. As I said, the apps will detect workouts, or they can log it themselves. There are also how-to videos for these exercises at the different levels. So this is an example of videos that are related to an arm workout. So you can do a wall push-up for many of our elderly patients. This may itself be a real workout. But we have some patients who are already really active, and we didn't want the app to be only oriented towards our older, more infirm patients. So the level 4 exercises really push even pretty fit people. As you can see, a decline push-up is a challenge for probably any of us. Then for the nutrition component, it's also a lot of exciting content that gets dripped over the course of the prehab program. So depending on the duration of their prehab, it's sort of 2 to 4 videos or recipes per week. So they're not overwhelmed, but they're also remain engaged. So the recipes include things like the basics, so some sweet potatoes or basic sauteed greens. There's also some videos. This is about sauteing and sort of a how-to videos of sorts. And all of these are focused on incorporating plant protein, fiber, and some healthy fats. There's also some really super engaging educational videos to give people healthy habits to move forward with, not just during the prehab program, but on an ongoing basis, about how to shop healthy. There's a really engaging video about seasoning in the face of taste bud changes related to chemotherapy, because a lot of our patients in the cancer center will have changes that we don't totally know how to react to. So they're pretty engaging, and to try to keep these patients interested in learning. Then on our side, we get a dashboard of the patients who are enrolled at any given moment. So there's a provider dashboard, and this one looks at all the patients that are enrolled and participating at any given time on a rolling basis, and in terms of adherence. And then for each individual patient, basically you can click into it, give that individual patient's adherence, and give the data that's getting pulled from their Garmin or their Apple Watch, or their heart rate and their steps and their sleep and their exercise. And with this constant feedback from the dashboard, our coordinator then can reach out to patients who are losing engagement to reinitiate their exercise plan and get them back on board and back into the groove to continue their prehabilitation.
So aim 3 was to pilot and operationalize prehab in our surgical clinics. We recruited patients who were being seen in the outpatient colorectal, surg-onc, HPB, and pelvic floor clinics who were about to undergo a major abdominal operation in 3 or more weeks. If they were amenable, we then talked to them more about the study. If they agreed, we installed the app on their phones. We set up their Garmin device if they didn't have an Apple Watch, or just linked their Apple Health app to our app, and then gave them the rundown on the study, sort of helped them through the enrollment survey, which is delivered on the app as well. And then depending on what their answers were to the enrollment survey, then we would set them up for remote coaching for exercises if they need. If they were sort of nervous about doing the exercises even with the videos, then we would set up sort of like video conferencing with them in their home so that we could talk them through the exercises. For patients who screened positive for malnutrition, or who just had a lot of concerns about how to follow the Mediterranean diet given their underlying condition, like if they were told never to eat fiber because they have diverticulitis, that sort of thing, then we would set them up with a phone consultation with a dietitian. And then if they were smokers, then they got directly referred to the Cancer Center's smoking cessation program. If they were risky drinkers, or if they were taking any of the drugs, then they get expedited referrals to addiction medicine. And then after that, we follow up with phone calls to see how they're doing. A lot of this is based on their adherence data that we can see on our dashboard. For example, if we see that there's no data coming through, then we'll give them a call to see if they need to troubleshoot their device, if it's not syncing potentially, or if they've lost the device, we need to send them another one, or if they just need a little nudge. And sometimes during these phone calls, it becomes evident that they need some extra coaching for, say, exercise, and we can set that up. And then we keep track of their exercises, and they get a little survey with each exercise to say, was this too hard or too easy? And then that tells us that we can titrate their level of exercise up or down as needed, depending on that feedback. So with our first pilot patients, we did 12 patients. And what we found in their feedback was that for some of them, having 2 new apps and 1 new device was just way too confusing. So, you know, if they're adding a Garmin, then they get the Garmin app, and then they get our app, and then they have this hardware. So, so that was one thing. For some patients, it didn't really matter. For the patients who were really tech savvy and weren't bothered by the extra apps, they were more bothered by some of the bugs and the user interface issues. And then what came out also was that we needed to have more flexibility built into the app, especially for the exercise program, because a lot of people like to do their own thing. So we made some iterations to the app, and this has taken us this last few months basically to get it to the point where we can go live with a bigger group of patients. So we streamlined it so that that patients would get less notifications from the Garmin and from our app. Basically, they were just getting bombarded from all apps and all hardware, and I think that was really stressing them out. So we made sure that when we gave them the Garmin, that we would turn off all the notifications from the Garmin so they weren't getting harassed all the time. We also resolved all the bugs. We made the user interface for our app better and more similar to the Garmin app, so that patients would sort of gravitate towards the Prehab app and therefore fill out the surveys and all that stuff that we wanted them to do. And then we built in an ability to customize the exercise plan. So if patients have their own exercise plan, or they want to switch from our exercises to their own, then it allows them to do that. Still, our challenges are space in the clinic. So it's just, it's a very busy clinic down in GI oncology. Even though consultation rooms are being used by the medical oncologist. So it's just sometimes hard to find space to do the enrollment. Also, as Brendan alluded to, a lot of patients are elderly. We try to use their caregivers, but sometimes they just really can't handle that level of technology. Some patients are totally off the grid, so they don't even use internet, so they can't be included. And again, most recently, the COVID-19 era has made it difficult for us to enroll. We weren't, doing as many operations electively. Scheduling 4 weeks out in advance is a little harder too, so we can't identify those patients. And also just not having a research coordinator in the clinic reminding the surgeons, hey, don't forget about prehab, that has also affected our enrollment. So our next phase is aim 4, that we're eager to start in the next couple months, and it's to determine the effect of this program on outcomes. The intervention group, so everyone's going to get the app. The intervention group will get the app with the prehab rehab program, the nutrition exercise program. The control group will just get the survey, so at least we get that data. The primary outcome is complications occurring within 90 days of surgery. And we'll use the comprehensive complication index, which is a linear score between 0 and 100. And then the secondary outcomes will be quality of life and health self-efficacy, basically from all the surveys that we collect via the app. We'll be enrolling adult patients who speak English, have a smartphone, and are having major abdominal surgery in 4 or more weeks. So we want to thank the division of the department for their support. Without this C grant, this project would not have been possible. We also want to thank our fellow surgeons who have talked to their patients about prehab and willing to let us invade their clinics a little bit and enroll your patients. So certainly we would definitely not be able to do this without you guys. And then also to our research coordinators, Kriti Shankar and Libby Shelton, for their hard work interviewing patients, recruiting, enrolling, following up, troubleshooting. None of this would be possible without their hard work and dedication as well.